Okay, thanks so much. Thanks very much to the organisers for inviting me. It's fantastic to be here. Before I get started, I've spent some time looking at the picture on the front of the conference programme, and I'm thinking, which one of those is the health economist? I think, because historically, health economists have not been very popular. How many of you think it's the guy in the dark blue? Not very many, right? But I would like people to start thinking of the health economist as the person in the dark blue, helping the other members of the team, also helping the woman in the light blue, looking ahead into the future. I think historically most people would think of the health economist as a fourth person standing just off screen, waiting for everyone to get to the top and then pushing them off the top of the mountain. So, what I'm going to do today is, first of all, talk about why I think considering cost effectiveness and economic evaluation is important. What's the moral basis for this? Why should we be doing it? And then I'm going to talk about where I hope we go, given the topic of this, the title of this session, is moving beyond cost effectiveness. Where are we going to go in the next 5 or 10 years? Where should we go? Here we go. So, I'd like you to imagine that we have a public healthcare system which has a budget. Now, this assumes there's a single-payer system, there's other possible systems, there's insurance-based systems, there's hybrid systems. Suppose for a moment that there's a healthcare budget, and there's a new personalised medicine technology. Now, we might be lucky. We saw an example in the first presentation of a technology that actually saves us money, right? It actually has negative incremental costs. And in that case, you wouldn't need to divert any dollars from the healthcare budget to adopting this new technology. It actually frees up some resources, which is fantastic. Those are not the norm, though. Right? In those cases, of course you'd adopt the technology. If it improves people's health and it saves us money, it's a no-brainer. The majority of cases, the cases where the health economists get involved, are those difficult cases where a technology requires additional resources. Right? It has an incremental cost, a positive incremental cost that falls on that healthcare budget, but it also improves the lives of patients. Right? There are some expected health improvements, and as Deborah just showed, maybe there could be benefits that go beyond health as well. Let's keep things simple for now. Let's focus on the health improvements. Now, we have a budget, and we need additional resources for this technology. So, unfortunately, something has to give. And you hear this term that health economists use all the time and people's eyes glaze over, disinvestment. Right? What it means is that we need to free up resources elsewhere in the system. And it's quite rare that that means completely delisting another technology. It can happen, but it's very unusual. Usually what would happen is local decision makers are told you must fund this new technology, and each local decision maker makes some very difficult decisions about where to free up those resources. And what you end up with is maybe slightly longer waiting lists for some existing treatments. It's true all across Canada, it's true in the UK, I'm sure it's true in most European countries, that you have waiting lists for routine treatments, things which are highly cost effective, and yet we often have long waiting lists for those things. And the dollars that we use for new technologies could be used to shorten those waiting lists, at least in principle. And by using those dollars for other purposes, there is an expected health loss, right, because of that displacement elsewhere. Now, we hope that a new technology provides greater health improvements than the resulting health loss, right, due to the displacement that arises when we reimburse that technology. So, what does economic evaluation do? Cost effectiveness analysis. That's a particular type of economic evaluation. It allows us to consider these expected health improvements and these expected health losses, and in turn consider what the expected impact would be on the health of the population. Right? And that principle about looking at the net benefit that reimbursing a technology would have, you can extend it beyond health, as Deborah just said. We could think of, the societal benefits beyond health, but of course there's also a societal opportunity cost. It wouldn't just be health losses. You'd have to think, well, okay, what are the productivity losses that arise from those health losses elsewhere, right? But you could certainly expand this beyond health if you wished. I think that when we do economic evaluation, the purpose should be to consider, initially at least, the health of the population. We can expand it if we wish, but we have to focus on what is the impact on the health of the population. It's not just an accounting exercise. Right? The reason that people like myself do economic evaluation is not because we want to be accountants and we want to just add up every cost. The reason that economists are interested in this is we think, what can you do with those dollars? What is the best way that you could use those dollars to improve the health of the population? That ought to be the focus. So I think economic evaluations have been criticized, rightfully, in the past. You know, we focus on calculating ICERs, incremental cost-effectiveness ratios. You compare them to a threshold that appears arbitrary. What is that threshold? Right? There isn't a very clear link to the health of the population. How does doing this improve the health of the population? I think we need to be very clear that that should be the goal and adopt some methods that help to achieve that goal. And the reason it's important to consider the health of the population and consider all the patients affected by a reimbursement decision is because it's important that every patient has a voice at the decision-making table. If we recognize that resources are limited, so if we put additional resources into a new technology, that means that those resources cannot be used elsewhere. Any impacts that result on those other patients, I think, ought to be taken into account. Otherwise, those patients don't really have a voice at the decision-making table. And something I should also say at this stage is there's a real problem in most countries with identifying who those patients are that bear the cost when we incur additional costs to adopt a new technology. Usually when NICE or a similar agency issues a recommendation to fund a new technology, that's not the same agency that will decide where the cutbacks need to be made elsewhere. Usually that's left for local decision makers, right? And you'll have different decisions made across the same jurisdiction by different local decision makers. So we don't know at the time that we make, or at the time that agency makes a recommendation to adopt this technology or not, we don't always know exactly who these other patients are, right? They're not there at the table. They don't even know that they're affected, right? If you were put on a waiting list for treatment and it was longer because a few months ago some money was diverted to spend on something else, would you know that? Would you know your waiting list is a little bit longer? No. Okay, so these patients don't necessarily have a voice, and doing this provides at least some voice to these patients. So, again, in principle, a technology should be considered cost-effective if its reimbursement is expected to improve the overall health of the population. That's a first principle. We can extend that. Right? As Deborah mentioned, we can go beyond health. But that's a sort of a foundational principle here, that new technologies, when we reimburse them, there ought to be a public good. This should improve the health or some composite of health and non-health benefits overall across the population. And conversely, we should consider that a treatment is not cost-effective if its reimbursement would be expected to diminish the overall health of the population. I emphasize the word expected there because very often we have uncertainty about how effective this new technology is. We have uncertainty about what the incremental costs of the technology will be. We have uncertainty about how those incremental costs convert into foregone health for other patients. Right? So there's a lot of uncertainty here. But our expectation ought to be that new technologies result in the population as a whole living longer lives, lives of better quality. Okay, now, a critical point here is converting between those monetary costs, the incremental cost that a new technology imposes on a healthcare budget, and the impact on other patients. Okay, so I think it makes sense that if you incur an incremental cost, the budget's constrained, it means either we have to displace something else, or at the very least, even if your budget were to be increased slightly, those dollars could be spent on other useful things, shortening other waiting lists, providing access to other treatments that are currently not funded, right, which would improve the lives of patients. So there's a relationship between the incremental cost that a technology has and the expected health loss incurred by other patients. Right? The greater the incremental cost of a new technology, the greater the foregone health by other patients. But how do we estimate that? Where does that come from? And it requires empirical analysis. And it is only within the last decade that health economists have begun to really tackle this problem. Right? Like, how much health do other patients lose when we divert money from our public healthcare system to a new purpose? So far, there have been a number of studies, peer-reviewed studies done by academics across Europe and in other countries. This is a paper. It's a bit small to see there. If anyone's interested, I can send you a link after the talk. Published within the last year, I was a co-author on this study. This looked at all of the existing peer-reviewed studies that have been published to date, which aim to quantify how many quality-adjusted life years are lost when incremental costs are imposed on the budget of a collectively funded healthcare system. Okay, so these are peer-reviewed estimates of the incremental cost required to displace one quality-adjusted life year. The methods are really complex, so I'm not going to get into them too much. All I will say is this. Some studies, and I'll just go back so we're not distracted by that slide just yet. Some early studies attempted to look at, what is it that we're actually displacing? If NICE in the UK were to say we should fund this new technology, what were local decision makers across the UK deciding about which technologies to displace? And the difficulty that the researchers had is that different local decision makers were making different decisions, and what they then tried to do was do cost effectiveness analyses on those technologies that were being, that less money was being spent on, and look at the incremental cost effectiveness ratios, and they were all over the place. It's extremely difficult to do that work because different local decision makers are making different decisions. So a new avenue of research has looked at what is that relationship at the margin of the healthcare system. When I say at the margin, we're looking at that last dollar spent, that last euro spent. How much health do we get for that last euro spent? So it's something called the marginal productivity of the healthcare system in terms of health. Right, so this research has attempted to estimate that. So in the UK, again, you have different local decision makers with budgets, they spend those budgets, and there's data on outcomes that we get from those budgets, right? So a particular regional health authority might spend a certain amount of money on cancer care, and you can look at the outcomes for that, and then another authority spends a different amount and gets different outcomes, right? So can you look at that? Can you do some kind of regression analysis and try and estimate how much it costs to get better outcomes? That's the approach that they've taken. The challenge that you have is from the endogeneity problem. The fact that those parts of the country that have the most money spent on health are often those with the greatest need. Right? So you find that those areas that have the greatest health needs, you observe the most deaths in a given period, will have the most spent on them. It doesn't mean that spending money on health is causing those deaths, right? So a bit like those areas of Paris which have the most police funding are probably those areas with the highest crime. It's not that spending extra money on police causes more crime, right? You've got an endogeneity problem. If you wanted to try and tease out, how effective are the police at stopping crime, you'd have to control for the differences in need across these different regions. And that's what they've done. And when you do that, you find that relationship flips. Those areas that spend the most have the best outcomes, and essentially they're doing a regression and looking at the beta coefficient in that regression to see how much extra you have to spend to get one additional quality-adjusted life year. That's all I'll say for now. If anyone's interested in these methods, I can talk more about it after this session. So a number of these studies have been done worldwide. The only ones that I'm showing here are the ones that were captured in that systematic review that I showed a few moments ago. I've also excluded those studies that did not report cost per QALY. They reported cost per DALY, which is a measure that's used in the developing world. So that means we've ruled out South Africa, we've ruled out China. Those estimates in terms of cost per DALY were very, very low, below $10,000 per QALY. I don't think that they're particularly relevant in a European context when you're considering what that cost per QALY would be. This slide I prepared for a Canadian decision maker, the Canadian Agency for Drugs and Technology in Health, CADTH. They give recommendations in Canada as to whether technology is a good value. So all the estimates here have been converted into Canadian dollars, but you can always convert these into euros if you wish. What we did is we converted all of the estimates from each country into Canadian dollars. We adjusted for purchasing power parity, we adjusted for inflation, because these studies were published at different times. I've also added one other country that was not included in that review, which is the United States. The reason I added that is that was some work that was done more recently from the systematic review, and it's very interesting because it's the first study of this type to look at an insurance-based system, so the private insurance system in the United States. Because earlier in the presentation I said, in a single-payer system, it's quite easy to see there's a constrained budget. If you spend money here, you can't spend it there. But what about in an insurance-based system? And you have a similar dynamic going on. If within an insurance-based system, if you want to fund a new technology, there's a few options at your disposal. One of them would be to raise premiums. Well, that would cause some patients to drop out of insurance coverage. And by dropping out of insurance coverage or by downgrading their insurance coverage to a cheaper plan, that will impact on their health. So you'll still have some health losses. Alternatively, if you don't raise premiums or you don't raise co-pays, you have a similar problem to a single-payer system that you don't have any more money within the plan, and so something will have to give, right? You're going to have to cut back on what you offer to members of the plan, and it's going to impact on their health. Whatever you do, if you're trying to adopt a new technology that incurs additional costs, there's going to be consequences in terms of health for some patients. And actually, in an insurance-based system, if patients are dropping out of coverage, have a little think about, is it the average patient that's dropping out of coverage? Or maybe it's those that have the lowest income? And think about that later in the presentation when we talk about equity. So let's not focus on the US, because I don't think it's an appropriate comparator, particularly when we're looking in Canada or in European countries. These countries that are left were considered relevant, in Canada at least. All of these countries are within the 11 countries that Canada uses when it does reference pricing of pharmaceuticals. What are the mean and median of these costs per QALYs across these countries? In the region of $30,000 per QALY. That's just a point estimate, though. All of these studies reported confidence intervals. There's uncertainty around this number. But that is the sort of ballpark that we're in so far from the research that's been published to date. What does this mean? It means approximately, if this estimate's correct, approximately every $30,000 that is spent on a new technology, if that money had instead been spent elsewhere within our public healthcare system, we expect it could have generated 1 QALY of health in other patients. So what does that mean? It means if your new technology costs less than $30,000 per QALY, let's say it's $15,000 per QALY, fantastic, right? If it's $15,000 per QALY, that means every $30,000 we spend on it, we're gaining 2 QALYs and we only lose 1 elsewhere, right? So we're improving the health of the population. But what if it's a lot more expensive? What if it's $60,000 per QALY? Well, for every $60,000 we spend on it, we gain a QALY. But that $60,000 could have got us 2 QALYs elsewhere. So we would expect that to diminish the health of the population. And you might say, well, what if our willingness to pay for health is higher than $60,000? The problem there is that you're losing more health than you gain. So even if you were to value each QALY at more than $60,000, the net monetary benefit will still be negative because you're losing more health than you're gaining. It's possible, though, that there are other non-health considerations that might tip the balance right, the other way. So we should always keep that in mind. Okay, now what about equity in the distribution of health? So far we've just talked about health improvements, health losses, but it's possible that the characteristics of the patients who stand to benefit are such that we might wish to assign a greater value to health improvements, right? Perhaps this is a technology that provides health benefits to patients with really severe disease, right? Maybe they have disabilities. Maybe they have a disease for which there's very few treatment alternatives, right? This is the first technology that's been created for this patient population, and for whatever reason, we wish to apply an additional value to their health gains. Right, so that's something that's been talked about. Many of you will know that in the UK, NICE has different cost-effectiveness thresholds. Until recently, they had something called an end-of-life threshold. So if your technology is for a patient population at the end of life, then a higher threshold would be used for those patients, effectively assigning a higher weight to their QALYs. So yeah, maybe even if your ISA is higher than that 30,000 or whatever the number is, it's still worth doing, right? Because of the characteristics of the patients who stand to benefit. And if that's the case, then we can move beyond just doing cost-effectiveness analysis. We can do something called distributional cost-effectiveness analysis, where we apply direct equity weights to the QALYs gained and foregone. And if anyone's interested in this, there was a book published very, very recently where I authored the chapter on direct equity weights, so if anyone wishes to talk about it, let me know. There's some algebra in it. I took all the algebra out of this presentation. There's a lot in the chapter. It talks about how you'd actually do this in practice. Okay, so I'm about to wrap up. One thing I'll say is, if you're going to go through the business of applying direct equity weights, there is some bad news, which is the patients who stand to lose out might also have these characteristics, right? I mentioned earlier that particularly in an insurance-based system, who are the patients that are going to lose out if insurance premiums have to increase to pay for the technology and some patients drop out of coverage or downgrade their coverage? It's not going to be the rich, right? It's going to be those in the lowest socioeconomic groups whose health is diminished by more than others. So if we care about equity, we really should be thinking about the socioeconomic characteristics of those patients who bear the opportunity cost. Are there patients with rare diseases or patients with severe diseases who bear that opportunity cost, right? So it can get really quite complex. Final slide now, some recommendations. The first one is that decision makers should support empirical research into the health opportunity cost of reimbursing health technologies within their own healthcare system. It will be different across healthcare systems. You would expect it to be different in health systems that have different budgets per capita, which have made different decisions historically about what to adopt within their healthcare system. You would expect that the cost, what we health economists call the opportunity cost, the consequences for other patients of spending $1, €1, £1 on a new technology, it's going to be different across these systems. So that empirical research needs to be done within each jurisdiction. Secondly, if decision makers support that sort of research, looking ahead 5, 10 years, it would allow us to adopt evidence-based cost effectiveness thresholds. They're no longer arbitrary, $50,000 per QALY, 20 to 30 pounds per QALY, right? You can actually have thresholds that reflect the impact that these costs have on the health of patients. Okay, it gives a voice to those patients whose health is diminished. It allows us to consider the net impact on population health. And then finally, the characteristics of those patients who stand to benefit and those who stand to lose health can be taken into account using distributional cost effects and analysis, using direct equity weights applied to QALYs. Thanks very much.
Thank you. I see hands in the air, and I believe there are roving mics. Oh, have I got to choose who goes first? I nominate the person over here on the right. I think his hand was the quickest.
Thank you very much to the three speakers for the complementarity of the presentations, and also because you managed to create an atmosphere of excitement for health economics. Mike, I would like to say that I think health economics should be also the light blue person, because cost effectiveness by definition is looking into the future. And I would like to introduce the element of the timeline here, because some personalized medicine interventions that are required to the policymakers are particularly challenging, taking into consideration that the budgets of the healthcare institutions are basically structured year by year. And this is particularly true for ATMPs, and I'm thinking the best example possibly is CAR-T therapies for hematological tumors. So the question is, how can introducing a change in the mindset of the policymakers to transform something that is interpreted as a direct cost into a long-term investment for people's health? Thank you.
Who would like to tackle that? Deborah.
Take a rest? Okay.
Okay.
Thank you for that question. Boy, is that a little sore point for health economists. Fundamentally, I would react to say that our budgeting structure not in every single healthcare system, but in many, I would say are incorrectly conceived. You used a very good term, which is we shouldn't be talking about the cost of anything around health, because we're investing in people's health. So the entire language, I would argue, needs to change. I also really dislike the term burden, because people aren't a burden. We are supposed to be helping them. That's what we're all here for. We work in health. So yes, and the way budgets are structured, we often talk, and there's actually quite a literature around what we call silo budgeting, which is we carve off different pieces. And by the way, I agree with you. That's what one of the things I wrote down is we should be the light blue people, because if we're talking about investment, by definition, you need to look long term. But many people's health budgets, again, health shouldn't be what it is. It should be health and wellness and everything else, social, education, justice, but is done on an annual basis. And it absolutely doesn't work as a consequence. So I think it has to fundamentally change, and we need to go to our very senior. It needs to be the Prime Minister or the President who changes these structures.
Because this is such an important question, I'm going to allow Ballas to say something and also Mike, but that's the only time that's going to happen in these questions.
I'll be quick. So just the example I've shown you, for the cost effectiveness analysis, so when we estimated the value of the intervention, it was mostly like at least 10-year, but sometimes also a lifetime horizon. That's normal and that should be done, but of course when to their future.
Thank you, Mike.
Just very quickly, the budget siloing is a real issue. It creates inefficiencies. We do, when we do economic evaluations, we do the basics. We ought to account for inflation. We ought to account for time preference through discounting down to a present value. But yeah, in terms of siloing, I don't know what the solution to that is. It's a real issue. One thing that you said that I think is really important is this language around investment and seeing the adoption, the reimbursement of a technology as an investment. And it's something which health economists haven't really used that sort of language, and I think it's helpful because when we use that sort of language, we can look to financial economics for some lessons about investments. What sort of return on investment should we expect from a new technology? Because a lot of the debate around drug pricing, particularly in Canada, there's been a lot of controversy over recent years about drug pricing. The government wanted to tighten its regulation, lower prices. The response of industry is, well, we're not getting sufficient return on investment. And it's an entirely legitimate argument. Of course they need a return on investment, or that there won't be future innovation. I think we should also use that language on the other side of the coin from the position of the healthcare system. The healthcare system needs a return on its investment when it reimburses new technologies. But that's not in terms of dollars, right, or euros or pounds. It's not money. Why is a public healthcare system investing? To improve the health of the public. So I think for a public healthcare system to invest in a technology, there ought to be a return in terms of population health, right? There ought to be a deal that over the lifetime of this technology, the health of the public will be improved. Maybe not initially. It might be that it's really when the technology comes off patent later, the price drops, that maybe we get some returns then. But at some point over that life cycle of technology, there needs to be an improvement in public health. How great should that return on investment be? Depends on how uncertain it is, right? If you come to market with a technology where there's highly uncertain evidence as to whether it's effective, perhaps the solution to that is not to say no, it's to say, well, okay, but we need a greater return on investment, because that's consistent with basic principles around return on investment. The greater the uncertainty, the greater the expected return should be. That then gives an incentive to those manufacturers to do high quality trials, come to market with better quality evidence, we're going to reward you, because it reduces the risk that we face as public payers when we make our investments. So I think we should just change our language to be around investment.
Absolutely. Okay.
Yes.
Yeah.
Yes, I have a question on the first intervention and maybe a comment on the last. What I understand, your studies at the end, you have three main parameters that are the prevalence of the disease, the cost of the treatment, and the cost of the diagnosis. Have you tried to make simulation models to predict the gain or the loss in terms of cost effectiveness to many cases? And my comment to the last intervention is that, in my opinion, it's not just the public, the taxpayers' budget, it's also that the payers are not the same. So the direct costs are on the insurance system, and if the employers are penalized, but it's a different, there are different payers. Over.
Okay.
Yeah, without going into the details of all the details of the economic evaluations, there were from the three studies, as I remember, two that were simulation models. I just didn't have a time to talk about this. I think simulation, as Deborah also talked about this, it depends on the complexity of the question or the complexity of how the patient progress, and if they have a history throughout the time that should be handled technically. So if it's not a simulation model, it doesn't necessarily mean that it's the wrong model. It's just that the question could be answered in a simplified structure as well. Yeah, two of the three were simulation models. Yeah.
Thank you. Okay, I'll allow one more question.
Thanks a lot. First of all, thanks a lot for the nice and complementary presentations that I agree that were really, for a subject on economics, were really interesting to follow attentively. So thanks for that. I was just missing one thing, and is that all the three presentations are focused on new therapies and whether we can or not integrate, or whether we should. So as if now we were in a situation where nothing should be assessed. And I was wondering, are there health economists looking also at the efficiency of procedures that are, or drugs or that are doing today and which probably should be stopped? I'm thinking, for example, how many MRIs, for example, are just prescribed. Are all of them necessary? Is anybody looking at that? And also in these kind of things, personalized medicine approaches could help, because many drugs should not be prescribed or prescribed differently. So I'm thinking whether this should not also deserve more attention in order to increase the efficiency of the healthcare systems, even without looking at innovative new therapies or whatsoever.
Okay, yeah. Yeah, Deborah, please.
I love that question. You're right. A lot of cost effectiveness does focus on actually drugs, as a matter of fact, because of the way a lot of it is because of the health technology assessment agencies and what's required by regulatory agencies. But to answer your questions, there is an increasing shift in awareness on what I'm going to call the health system perspective, because if you think of it, and actually if you look at the distribution of dollars in a healthcare system, the large majority in any system is about the delivery. It's the cost of people and how to do this better. We've certainly learned in COVID that maybe there are alternative ways of delivering care. Doesn't always work, but in some instances, telemedicine can be a fantastic and also very cost-effective way of delivering care. This also links into the question around simulation models, and in fact, that methodology, which actually is derived from operations research, is about increasing the efficiency of delivery of service and production processes. So I would advocate, and this is why I had simulation models up there, is we need to be looking at the long-term trajectories and delivery more broadly. So absolutely, I agree with you.
So you can only see 4 health economists here. There are economists that have specialties in health. So colleagues of mine work in the economics of patient safety, the economics of adherence. That's all about using the medicines we have more effectively, or having safety systems within healthcare to avoid harms. So yes, it's an interest, but you don't tend to see that sort of work presented, because you only get a little snapshot of what health economics can offer, at which point I shall cease talking. I think hopefully you've had a nice little taster of what we can offer. We're all around over coffee. Please come and chat to us. We don't have many friends, so we're happy to talk. I hope you enjoyed the session. Thank you.
That's because we pushed them off the mountain.